My second topic is about acoustic immittance measures. Do you have any idea what is this topic about? Normative. Good. So what is acoustic actually? Anything related to sounds, the production of sound, the transmission of sounds, as well as the absorption of sound. Okay, a bit of introduction about this topic. Acoustic immittance, in contrast to pure tone audiometry, okay, which PTA is the test of hearing. Acoustic immittance measures is not a test of hearing. Okay, it is not a test of hearing. So maknanya you tak dapat hearing threshold. Tak ada air conduction, tak ada bone conduction threshold. Okay, and it is a test to measure how well your middle ear status is. Okay, so the middle ear status, not measure how well it is. Okay, how well is the tympanic membrane, the ossicles, as well as the eustachian tube. Okay. It is an objective assessment. Okay, so you do not require any response or participation from your patient when you conduct this test. Okay, you just plug in, okay, and then wait for the results. But you have to explain or instruct your patient not to move around, because if your patient is moving, you will get an artifact, or your results will not be reliable. Okay. So because it is objective test, you can conduct this test as young as newborn baby up to elderly. Okay. So what is acoustic? Again, it is a study of sounds, including productions, transmission, and absorption or reception of sounds. How about immittance? What is immittance? So immittance is a generic term, okay, that explains two concepts which is inversely related. What are two concepts? I think you have heard about this: impedance and admittance. What is impedance? The impedance is about how middle ear resists, okay, the energy or the sounds for going through. That is impede. Okay, you halang. So maksudnya bila your middle ear system is has high impedance, maksudnya your middle ear system is stiff. So majority of the sound is not transferred towards the middle ear, it's being bounced back. That is impedance. Okay. Admittance is vice versa. Maksudnya the middle ear system allows the majority of the sounds to be transferred through. When this happens, okay, your tympanic membrane and your ossicles can vibrate freely. Okay. In ideal situation or for healthy middle ear system, we want them to be high admittance and low impedance. Tu tak stick. Okay, dia boleh vibrate. Okay. So when we talk about immittance measures, okay, there are two tests that are usually involved. It is not only tympanometry. It's also include acoustic stability reflex test. So bila you nampak acoustic immittance measures, it's involved these two, okay, tymp and reflex. So what is tympanometry? Again, this test is used to detect middle ear pathologies. It's very good, very sensitive. The sensitivity can be as high as 98% to detect middle ear fusions. Okay. And you need an immittance meter to conduct or to perform this test. And the principles of tympanometry is you need to measure how well the middle ear works in response to when we vary the air pressure. Okay, air pressure tu maksud air pressure in the canal. Okay, so that's why we have sound generator in that immittance meter. We have sound generator, this part, And we have probe tone generator as well. And the sound generator is to present the stimulus, okay, use whether you nak guna 2 to 6 hertz frequency or 1000 hertz frequency. For adults or older children aged more than 7 months, the probe tone frequency that is recommended for tympanometry is 2 to 6 hertz. But for young babies less than 6 months old, we use 1000 hertz frequency. Okay. We have microphone in the system to record the admittance or the reflected sounds energy, and we also have air pump pressure, and the purpose of air pump pressure is to vary the air pressure in the ear canal. Okay. So this is an example of immittance meter. You can have non-portable one, and you can also have portable one. Okay, the one that I highlight is called probe, and this is the most expensive part of acoustic immittance meter. If you broke this down, it costs you about 30,000 to replace it. Okay, it's very sensitive because it consists of the 3 or 4 tubes tadi tu. Yeah, the air pump pressure, the microphone, as well as probe tone generator. Okay, and it comes together with variation of probe tip size. Okay, you can choose from small one to the largest one. Usually it looks like mushroom. Okay, and you choose depending on the size of your patient's ear canal. Once you have chosen, you have to put it on top of the probe tone meter, probe tone, and then you inserted it to your patient's ear. And the machine or immittance meter will run the test automatically. Okay, and this is what we will get from tympanometry. From tympanometry, it is called a tympanogram, and tympanogram by definition is a graph, okay, that represents a relationship between admittance or how the ear moves or works in response to variations of ear canal pressure. Okay, a bit of explanation that I want to highlight here. Okay, usually we start the machine. We start the testing at very positive pressure, plus 200. Yeah. Very positive. What happened to your middle ear system when we start at very positive pressure? Look here. It is very stiff. How do you know it's stiff? Because there's no admittance recorded, it's 0. Okay, it's very stiff. Maksudnya kebanyakan sounds is bounce back. Okay, as we decrease the pressure, you can see that the admittance is slightly showing up, increasing. Okay, so it means that your middle ear system is moving now. Okay. The middle ear moving now until it reached the peak here. At this peak, what happened to your middle ear system is that your middle ear system vibrates freely. So maksudnya semua bunyi itu being transferred, okay, towards the middle ear system. And again, after that peak, you can see that the admittance reducing until the very positive pressure. It means that it's come to the state of stiff balik. So that is definition of what tympanogram is and how it is the relationship between admittance and ear canal pressure. Okay. What does it tell? So you can, when you perform tympanometry, you can get some information about the shapes, okay, of the tympanogram. Okay, as you can see here, there are plenty of shapes. Majority of them are single peak graph. Single peak, not double peak. Double peak is not considered as any type. It's considered double peak tympanogram. So mostly you get this type, single peak, and there's a normal one, normal peak, very high peak, low, very shallow peak. Okay, and then you can see that the peak is shifted towards the negative side. Okay, and there's one shape whereby the graph is flat. That is shapes. It's all about shapes. We explain about the shapes. Okay? And you can also get information about the tympanometric values. Okay? We want to know about the values of static compliance or static admittance, this part here, or we can call it the height of the tympanogram if you have single peak tympanogram. Kalau tak ada single peak, you cannot get information on static admittance or static compliance. Okay? Remember, it is the height of tympanogram. Okay? We also want to know about the value for ear canal volume, or the volume in the ear canal between the tip of the tympanogram until the tympanic membrane. What is the value? Whether it's fall within normative range or it is out of normative range. And the third parameters that we also like to know is called tympanometric peak pressure. Okay, the pressure where the peak happens. Okay, you want to know all this. So when you interpret the tympanogram, you are not looking only at the shapes. Okay, you also need to look at the values of the three parameters to classify whether it's normal or not. Okay. So this is when you talk about type A is corresponds to normal middle ear function. Okay. So this is the general normative value for each parameters. Okay. So for static admittance, these are the values within this range. If you got values within this range, it's considered normal. Okay. For TPP, you have to differentiate whether your patient is adult or pediatric, because there are different values, as well as ear canal volume. So for audiology student, we want them to remember this, memorize this. Okay. So normal tympanogram is associated with type A tympanogram. How do you know it's type A? When you have single peak shapes and the values are within normal range. Okay? And if you have hearing loss, which type of hearing loss is having type A tympanogram? Sensorineural hearing loss. Okay, that's good. Okay. Otherwise, if you have type A, is associated with normal middle ear function. Maksudnya middle ear tu healthy lah, tak ada block semua tu. What are abnormals? Any shapes beside type A are considered abnormal. Okay. Okay. Like in this graph, AD is associated with very high peak. Okay, when you compare to normal type A, maksudnya the static admittance is beyond what value? Static admittance beyond what value? 1.5. Okay, the peak is higher, value is higher, more than 1.5. And for AS is shallow, the peak is below than 0.3. Static admittance 0.3. Okay, that's the difference. When you look at the shapes, they are all similar, single peak, but that yang determine the differences are all the static compliance or admittance. Yeah. How about this one? This is called type C tympanogram. Okay, and as you can see here, the peak is shifted towards very negative pressure. Okay, it needs to be more than minus 100 for adults, for pediatric, minus 150. Good. This one, type B. Nampak mana graph dia? Very flat graph is type B. Okay, type B. Which middle ear disorder is associated with this tympanogram? Otitis media with effusion. How do you know it's due to otitis media with effusion? Yeah, you look at ECV value. As I mentioned before, flat graph, the only value or parameters that you can get is ECV. The rest if you see static admittance tu tak ada sebab tak ada peak. Okay? Right. So type B tympanogram can be due to many pathologies. One is perforated eardrum, grommet tube in situ. Ni apa ni? Bubble middle ear effusions as well as impacted earwax. How do you differentiate between these two? Between these pathologies? You look at the ECV values. That's why I ask you to memorize the ECV value. Memorize, okay? So if the ECV value is within normal range, okay, the possible pathologies if you have type B tympanogram is middle ear effusion, or if you have grommet tube, if it is normal, it means that your grommet tube is not functioning. Okay, ada dia block tu dengan fluid. Okay, for if you have type B with small ECV, okay, it indicates that your patient may have impacted earwax, and you can cross-check that with your otoscopic findings, and maybe your probe is against ear canal wall. Okay, maksudnya positioning tak betul lah probe tip tu. Okay, and the third criteria is type B with large ECV. It is associated, can be associated with perforated tympanic membrane, and if you have grommet tube, it is fake patent, meaning it's functioning. Okay, right. So summary, a bit of summary. How do you summarize tympanogram interpretation? So for type A, the shape is, you can always get the shape. There's always a shape. Okay, and it's a single peak shape. Okay, and all parameters are within normal values. For AS, you have single peak, but the difference is only static admittance, whereby it is low. So for AD is in contrast, the static admittance is high. For C, everything is normal, okay, except that the tympanometric pressure is shifted toward negative pressure. And last but not least is the type B tympanogram. You can differentiate the pathologies based on the ear canal value, whether it is normal, large or small. Okay, so tympanometry or tympanogram is very, as I mentioned, is very sensitive to pick up middle ear disorders. But how about acoustic staphylococcus reflex? So acoustic staphylococcus reflex is very good in differential diagnosis. Whether you want to differentiate your patient has cochlear loss, retrocochlear pathology, or brainstem pathology, okay, and a bit of staphylococcus ASR. What ASR is a contraction of staphylococcus muscle in response to loud sound. Maksudnya, you need to have a very loud sound to contract your staphylococcus muscle. So how loud is loud? It's in general, it's more than your conversational normal level. Kita bercakap ni needs to be more than 60 dB. Okay, right? So what happened when you do your acoustic staphylococcus reflex measurement? Either ear, bila you bagi bunyi in either ear, kanan atau kiri, tak kira lah. So both staphylococcus muscle will contract. That is the principles. Okay, maksudnya bukan bagi satu kanan je yang contract, tak, dua-dua contract sekali. Okay, and what happened during the contraction, during that process, your staphylococcus muscle will pull the stapes away from the oval window. In response to that, the sounds will be reduced by 5 to 10 dB. Sounds of entering the cochlea. Okay. So how ASR is performed? We are using the same machine, acoustic immittance measure. Same machine we use for tympanometry. Okay, and it need to be conducted immediately following tympanometry. Okay, maksudnya bila you start buat tympanometry tinggal kanan tu, you tak boleh habiskan tinggal kanan, lepas tu buat tim tinggal kiri. No, it is not the correct procedure. You kena buat tim, following that, terus buat ASR. Okay? Right, that is the correct procedure. And you kena get information for ipsilateral and contralateral ASR. What is ipsilateral? Bila ada ipsilateral? Ipsilateral maksudnya you measure sebelah telinga. Maksudnya telinga tu telinga yang you bagi bunyi. Ataupun in other terms we call it uncross reflex. Okay. Contralateral ni nama dia lain dia cross reflex. Okay. Maksudnya bagi bunyi kat telinga kanan tapi you measure dekat telinga kiri. That is contralateral reflex or cross reflex. So this is an example of ipsilateral reflexes. It's ipsilateral right reflex, whereby we introduce or we deliver sounds or probe tone to the right middle ear, and then we measure it from the right ear as well. For contra, okay, bagi bunyi dekat telinga kanan, similar headphone kat sini, buat probe, you letak dekat telinga kiri. That is contra. So this is an example of ASR findings. Okay. Look at this graph. You can say that the audiologists use 2 to 6 Hz probe tone. You can tell that your patient is at least 6 months of age. Kan? Okay? Or adult lah. We are using ipsilateral reflexes. Look at this one. Here it denotes ipsilateral reflexes, and the stimulus that we are using is 1000 Hz. Okay, to contract the stapedius muscle. Okay, and when we do reflexes, what we want to measure is the acoustic stapedial reflex thresholds. Okay, thresholds again, the lowest intensity that can contract stapedius muscle. And what is the value? Okay, the minimum value is 0.02 millimoles here. Okay, when you do, in this example, we started at 80 dBHL. Okay, and you want to look whether there's a deflection. Deflection maksud turun ke bawah, graf tu turun ke bawah ataupun ke atas. Okay, tapi kalau ke bawah, it need to be ke bawah consistently lah. We call it downward deflection. You cannot have downward and upward deflection in one stimulus. Okay, kalau you ada tu, you cannot get that as your finding. You call that as a finding. That is artifact. It need to be consistent. If it is downward, it's downward. If it's upward, it's upward. The majority of us, 90% of us, we have downward deflection. Only 10% yang ada upward deflection. Okay, so we started off with 80 dBHL. We look at downward deflection. Nampak macam ada, and it's consistent with the values 0.02. And then, if you want to confirm whether 80 dBHL is the reflex threshold, okay, you increase by 5 dB. By logic, if you increase intensity, the deflection should be more, kan? Okay, so look at here, you increase to 85 dB, and you can see that the deflection is getting stronger, 0.03. So you can say that the ASRT values for 1000 Hz is 80 dB. Okay? Boleh ya? How about this one, 2000 Hz? What is the ASRT value?
So 90.
50.
But 85 don't have, so 85 also cannot kira lah. So 90 only.
But the lowest you said
Ada intensity in between. Okay, for 2000 Hz, okay,
Repeat.
you need to confirm. How do you confirm whether 90? It cannot be 85 or 90 because there's no deflection here. It's 0.01 kan. Remember, it need to be at least 0.02. It doesn't matter if it is 0.05 here, it's okay. But you need to confirm whether it is true ASRT or not. How do you confirm? You increase lah to 95. Tapi dia tak sempat nak buat ni, audiologist ni. Okay, kalau tak tahulah kenapa. Maybe audiologist is in a hurry kan. So tak sempat nak buat 95 tu. Okay, we cannot tell whether 90 is the true threshold ataupun tidak. So if it is a threshold, okay, you increase to 95 dB, you expect that the admittance is larger. So kenalah lebih daripada 0.05. Kalau betul, yes, you can say that 90 is the ASRT for 2000 Hz. Okay, clear? Okay, what are the possible findings? You can have normal ASRT. Normal maksudnya if the threshold is within 70 to 100 dBHL. You can also get elevated reflexes if it is at 105 dBHL. Okay, and we can also have absent reflexes. Maksudnya there's no reflex response even at 105 dBHL. Okay, these are the three possible findings of ASR. Okay, this is the best part of reflexes, whereby you can differentiate based on the findings whether your patient has different pathologies. Okay, this one is about cochlear loss. Okay, imagine that, let's say that your right inner ear or cochlea is having a problem here. Depending on the degree of hearing loss, okay, you can either get normal reflexes, elevated reflexes, or absent of reflexes, depending on the degree of hearing loss. Okay, so in this example, okay, it looks like the inner ear is badly damaged. Okay, when you do ipsilateral right, okay, remember you bagi bunyi kat sini, it need to go through inner hair cells. The result is absent. Okay, so when you conduct ipsilateral left, ipsilateral normal, expected to have normal results. Okay, contra right maksudnya bunyi stimulus you bagi pada telinga kanan. Okay, and you measure pada telinga kiri. So sebab inner ear ada problem, you bagi bunyi telinga kanan, bunyi tak boleh cross to the left ear. So akan dapat absence of reflexes. Okay, for contra right. Contra left, no problem, normal. Sebab everything normal, pathway dia normal. Okay, this is an example of cochlear loss. How about retrocochlear pathology? Okay, so you have tumor here. Okay, when you do right ear, okay, still tak dapat reflex sebab tak boleh nak go through sebab ada tumor. Okay, when you do contra right, tak dapat kan? So still stimulus it go through the pathway. Contra ipsi left normal, contra left pun normal sebab pathway dia tak ada block. Okay, as easy as that. Senang kan reflex ni. Facial nerve pathology. Okay, in this case right ear has facial nerve pathology. When you do ipsi, tak dapat lah, absent. Dia ada pathology kat situ. Contra right present sebab signal tak lalu pun pathway tu, sebab signal kena cross over to the other ear. Nampak ni? Signal lalu sini, lalu inner ear, lalu auditory nerve, cochlear nucleus and cross ke telinga kiri, di mana kita measure probe kat sini, probe measurement kat sini. So that's why right contralateral is normal. Okay, but ipsi left you've got normal, but ipsi contra left is abnormal sebab sounds kena travel through the pathology side tu kat sini. Okay, that is for facial nerve pathology. Middle ear pathology. If you have bilateral middle ear pathology, okay, biasanya akan dapat absent. It can be due to probe effect ataupun stimulus effect. Pernah dengar? Pernah? Doktor mana dah ajar? USM? Probe effect ataupun stimulus effect. Probe effect ni bila your probe is put ataupun diletakkan di telinga yang ada pathology. Okay, let's say your middle ear is normal here, left middle ear is normal. So you bila buat ipsi left, okay, you got presence of reflexes. But your right is having middle ear pathology. So you bila buat contra left, sound you delivered ke sini, but your probe is measured here. Okay, so you tak dapat measure the reflexes because of the presence of middle ear pathology. That is probe effect. Okay, stimulus effect tu maksudnya bila you ada middle ear pathology, okay, the stimulus is not loud enough to elicit the stapedius muscle. Okay, so bila stimulus effect, your stapedius muscle does not contract, but for probe effect, it is contracted, but it is not being picked up because of the presence of middle ear pathology. Itu beza antara probe effect and stimulus effect. Okay. So intra-axial brainstem pathology, this is very rare. Okay, 1 in a million if I'm not mistaken, if you balance. So the characteristic of this for ASR for this pathology is presence of right and left ipsi, but the cross reflexes are absent. Okay, I think this is my last slide. Itu saja. Any question on reflex?
So they ask about what the contraindication for the stapedius reflex test.
Contraindication. If your patient has tinnitus, please don't do reflexes because it can trigger the stimulus. It's too loud. Okay. If your patient has otalgia, pus in the ear, please don't do because it's going to suck it's going to broke the probe. So jangan kenalah benda tinnitus. This is a contraindication, especially for ASR. Profound hearing loss, you tahu kan? Profound hearing loss. You're not going to get reflexes. Tak buat lah. Tak buat. Tapi for audiology student, kita harus buat juga practice. Okay. Indication. One of the indication, you need to look at the recruitment. Oh, you're talking about recruitment. Okay, recruitment is associated. Sorry? That's when you need to apply cross-check principle, whereby you need another test to collaborate to make sure that your findings is consistent. So cross-check ni maksudnya you guna different test. Satu subjective test, and you need to complement it with objective test. If you do your immittance first, okay, to ensure that it's due to cochlear pathology or retrocochlear pathology, that's why you need to have your PDA. Itu cross-check principle. You tak boleh solely based on ASR saja. You kata, oh definite this is cochlear retrocochlear pathology. You need to apply that cross-check principle. Guna subjective test, PDA lah, ataupun whatever variable measurement that you can get from your patient. Okay? Yes.
If let's say you mentioned that there is a probe effect, stimulus effect. If let's say there is a presence of clip inside the middle ear, can we increase the intensity of the stimulus?
It depends on the earbone gap, Prof. If your earbone gap is 30 dB, there's a 50-50 chance. Kalau you increase pun, you akan dapat ataupun tak akan dapat the reflexes. From my experience, biasanya tak akan dapat. Even though 10 or 5 dB pun, you akan dapat absence of reflexes with the ear fusion.
For ENT doctors, we rely on the stapedial reflex reflex when there is a traumatic facial palsy as part of the topo diagnosis test. So we are not looking at the stapler reflex in a normal daily patients in the clinic.
Yep.
So besides traumatic facial palsy, what else that the audiology need to what are other indication you want to do stapler reflex?
For facial nerve,
No, other than facial nerve.
other than facial nerve,
Secondary to traumatic facial palsy.
we do it for malingering, okay, to justify whether the patient has betul-betul ke ada hearing loss ataupun tidak. That because it's an objective test, they can lie, but with using objective test, we can determine whether it's true or not. Okay. Okay. Masa you belakang awak tadi. Aduh. Okay.
Which condition produce an elevated acoustic reflex?
Oh, elevated reflexes is usually associated with moderate to severe sensory nerve hearing loss. Okay.
Thank you, Professor Rafidah. Now